Hello, my name's Sam Jones. I have the honour of leading the New Care Models programme. But before I start, first of all, it is so intimidating presenting stuff about the vanguards to many of the vanguards in the room. So could you please forgive me if I get it wrong, if I'm not necessarily reflecting what's actually happening in practice, and if you can just kind of wave your arms in the air a bit if you need me to correct something that I've said. I stand here, yes, as somebody who leads the New Care Models programme, but I just want to start by saying, actually, I'm also the daughter-in-law of some very elderly parents-in-law who are experiencing the best and the worst of the healthcare system that we have. My husband and I and our family are navigating it. I sat on Sunday evening watching a GP phoning switchboard to get through to the on-call registrar because my father-in-law had probably a blocked catheter. I could have told her, we all knew it was a blocked catheter, but she needed to get that clinical advice. So she went through switchboard. She stood there for 7 minutes waiting to get a response from switchboard, to then have advice from the on-call registrar. The whole thing took about 20 minutes for the GP to actually get through. And I'm sitting there and I'm thinking, it's 2017. I'm literally rugby tackling this poor GP to make sure he goes nowhere near an A&E department because his catheter was actually blocked. And I use that as an example because, like many of you, I am somebody who uses our healthcare system all the time. We should never be afraid of saying what's good, of which there is a significant amount, but also things that we need to do better. We've got technology, we've got relationships, but we've actually got things that we need to improve. So it was a really good reminder for me on Sunday about why I personally do this and why many members of the team and what this is really all about. So when we come to talk about the contracts and the commissioning arrangements and the things that we need to do around regulation, which are all, of course, extremely important, it's also about remembering that at the heart of this are both individuals and the population that we serve up and down the country, that we are trying to improve the care that we give through the care models, irrespective of whether they're multi-specialty community providers or whether they're PACS, the primary and acute care systems, or the ACCs, the acute care collaboration vanguards, who if I missed, the care home vanguards, and also you'll hear a bit more about primary care home a bit later on. So the 5-year forward view beautifully articulated what we know. Many of us who were working in the service know about the health and wellbeing gap, the care and quality gap, and of course the funding gap. And I'm just going to stop for a second. When we started the programme, I felt very, very strongly that we needed to make sure the values of what we were trying to achieve and how we were trying to achieve them were kind of all the way through everything that we did. So it sounds extraordinarily obvious, but if we do not have clinicians involved in the shaping, the design, the planning, the thinking around care models, there is just no point in us doing anything. I have scars on my back from when I have tried to change clinical services and I haven't either had clinicians involved or indeed the local community, because unless we get that right at the beginning, we will not be able to make the changes that we all know we are trying to adapt across the country. If I had my time again, I would change it from being around patient involvement. I would make it about user involvement, because it automatically assumes that there's a patients when we are talking about care models, but actually the care models are around the local community, they're around local government, they're around people who are the voluntary sector, so people, carers, families, as well as, of course, individuals themselves. So the second value of the programme, and indeed we ask the vanguards to show and consistently show all the way through, is how have patients, users, families been involved in the shaping of the care models, not perhaps the more traditional way. We like to parody about, we've got a great idea, then we'll go and put in a room together and then come out and consult on it. And you'll hear some extremely impressive examples around how people who have used the services are actually designing them and fundamentally challenging our existing ways of doing things. I spent about 20 odd years moaning about the national bodies, if only they got out of our way and let us locally do what we needed to do as a chief executive. Then the principle behind this value is that the vanguards are local. There are about 15, 16, 17 different organisations working together within our existing architecture, which is challenging, but it's about local services. It's the population the local population that is being supported by that vanguard. And our job through the national programme is to work across all of the arm's length bodies as a vanguard challenge in itself, and to support the local vanguards to deliver the changes that are needed by moving the blocks out of the way. So our job is not to do. So I don't do the care models. I haven't actually done anything for a couple of years. I'm not the one, my team will tell you that, I'm not actually the one that is doing the really hard stuff. So our job through the national programme is to support by moving those blocks out of the way. So these are the vanguards up and down the country. I have a notoriously bad sense of direction, but they cover the whole of the country. And just to remind people what these care models actually are and what they are in practice. So we do like a three-letter acronym, as we know, but PACS, not those of you that perhaps have a radiology background, we're not talking about PACS from that perspective. We're talking about integrated primary and acute care systems working together. This is around, based on the registered list, the population that is being served by the registered list, primary and acute care systems working together. Multi-specialty community providers, they are what they say on the tin, based on the registered list, always a clue here, for the population that is served, multi-specialty, multi-agency providers working together, and not just the NHS. There's some extraordinarily impressive examples with the voluntary sector leading the way, the voluntary sector actually in the vanguards, being the ones that are designing and implementing the care models. The enhanced health in care homes, I still can't say it, serving the most vulnerable of our population in the care homes, but also, again, the support, using the communities in a different way for those residents outside of the care homes also. Urgent and emergency care, it is what it says on the tin, and acute care collaboration is around standardising of care, reducing variations across the country. I think it's something that we all know, those of us that have worked in the service, we know the difference in care that is provided in one part of the country to the other. This is around reducing the variation, both in terms of clinical care and also in terms of back office. We do like a template, and we did ask the vanguards what they needed to deliver the care models. For those of you that haven't had a chance to watch the compulsive viewing of the vanguards presenting, we filmed it all, it's all on YouTube, and we then asked the vanguards to vote so that they could help us decide who are the people moving forward. We then said, tell us what gets in the way of those care models being delivered. We could probably ask many of you the same question, indeed many people outside of the Vanguard programme itself. And we put it together in the what I like to call the Flower of Scotland, which is just a way of remembering what it is. It is also based on the work from the Health Foundation, who helpfully published a document in 2015 and said, why haven't the changes that we've been trying to deliver had traction and sustainability? I've heard all the jokes about pilots and BAs, you know, all of those things. I've heard all of that over the last couple of years, and indeed I've been involved in many of those pilots. And the Health Foundation, of which we've tried to base our support package, talks about the type 1. So that as you're looking at it, on the right, which are the policy changes, that the policy levers that need to be adapted. So commissioning, we know the commissioning, the contract at the moment, we know tariff, we know the payment systems don't support and best incentivise the right approaches to the care models as we talk about them. So NHS England and NHSI working together to support the delivery of those new commissioning arrangements. Governance, accountability and provider regulation. I was trained to be a provider chief executive for my institution. Population health systems are very different. What does that actually mean from a board's perspective? What does that mean? Because you can't lose your accountability and the governance responsibility for your organisation, but of course it is also about the system. So working with NHS Improvement, NHS England and also the CQC are designing with vanguards real time what the new governance, accountability and provider regulation looks like in practice. And we have vanguards involved all the way through, and indeed holding the national bodies to account on things that are working or don't work as they design the new policy. So this isn't just about what's happening in the vanguards. This is also about making sure that policy changes are adapted as real time as is humanly possible for the wider NHS, because for those of you that will have read the mandate. I'm sure many of you will have done so. It talks about the spread of care models affecting over 50% of the country by 2021. So this is real-time change, and you'll hear a lot more from Charles around evaluation and metrics and making sure we understand and measure what's happening real-time, but also, we're also, of course, with an independent evaluation. Empowering patients and communities, the bubble on the bottom, there is just no point, I will keep saying this, and there is no point in us trying to do things the way that we've always done them. So we had patients, carers, voluntary sector involved in choosing the vanguards, identifying the vanguards. We had a beautiful moment with, I don't know if there are any of the acute care collaboration vanguards here, when somebody got to the end of their presentation and this chap said, "That was very interesting, thank you, but I've absolutely no idea what you were talking about," because of the language that we use. And I'm still explaining to my 82-year-old godmother what a vanguard is, and using the words that people, of course, understand, and in making sure they are involved, because this is not about being done to, it is about me, and understanding me as a user and as somebody of the community and what I need for the future. So technology, it is obvious, of course. I was very excited in my old organisation that we were getting Wi-Fi. It was 2015 when Wi-Fi was coming, and the technology that is available for us. You know, we're here this morning about an app. I'm not even going to try and pretend that I'm anywhere near technology literate, but there's a huge amount of work going on to support the care models, first and foremost the care models, with the technology around it. So on the left-hand side, we have the type 2, we have the softer, but yet arguably harder behavioural changes that are also needed to change behaviours and understand why things haven't happened. So there is leadership that is required all the way through to have those difficult discussions and to understand what this means, putting our organisational sovereignty second and putting the population health first. That requires support for leaders all the way through, whether it's in primary care, whether it's in community providers, whether it's in local government. So we've been supporting through the communities of practice, of which the King's Fund support, as well as mentoring and coaching for those individual clinicians or those clinical teams who are involved in these changes, because it's those things that make a difference and the glue to support the changes that we're talking about. Unashamedly, we're all over social media, using every single form of communication and engagement tool possible. We have an online collaboration tool, Cahoots, which you're very welcome to join. You just need to let us know. We know that sharing is at the heart of everything around the care models and spread, so if you're interested, please do let us know. If you want to know about population health analytics, we have a chat room or a webinar thing. If you want to know what an extensivist service is, we have that as well. So the online platform is there as something from the legacy for the future, but also the use of social media, because there's a fact that I heard the other day, which isn't actually a made-up fact, that more people have access to social media than are registered to vote. So if that is the case, many of us will know that is, then how we communicate and how we involve people in the design and the delivery of our services moving forward is crucial that we do so. In terms of workforce redesign supported by Health Education England, it is also, yes, it's about the type, whether it's about more generalist, more specialist professionals, but it is also about supporting people through the changes that are required. If it takes 15 years to train a doctor, we've got 15 years of this workforce who actually need support. I trained as a paediatric nurse, kind of not right now for the future. You'll be glad to know I don't practice. But I would need support to be working in the community in a different way, and vice versa. We're asking people to work in a very, very different way, and we're investing time, effort and support through the support package to make sure we understand what that is in practice. And you'll hear a bit more from Nav a bit later, who also is a part of the workforce group, holding us to account on what's actually happening on redesigning the workforce. So the last year, I think a year in the new care models team is probably like a dog year for people. It's been going for about 7 years. It's actually been around developing and delivering the new care models. And as Chris said, early signs of impact are emerging. And we've had some badges made up in the team, depending on how we're feeling, and Charles will talk a bit more about it later. We're mildly optimistic, we're cautiously optimistic, it's not statistically relevant, There's some signs of impact emerging because we're walking a line here. Everybody wants to know what the results are. Everybody wants to know, and people understand from an evaluation perspective, this stuff takes time. But we are seeing some signs of impact. And I'm not going to steal Charles's thunder later on, but we have had some very encouraging indicators of progress and positive impact around emergency admissions, attendances, elective activity, and also within the over 75s. And we're working with the individual vanguards to test and evaluate the local findings, because this is all aggregated up, and it's around making sure, because this is the vanguards data, that that it's accurate, that we understand it, and that it is something that we can share, understanding and being able to confidently say this is the impact that the vanguards are having. But of course I couldn't get through a session without talking about some of the impact that we're seeing from some of the vanguards. Do we have anyone from Fylde Coast and Sunderland? Hello, sorry, I did see you earlier on. Hello. I'm just showing you back your data. That's okay. So if you haven't seen the work that's going on in any of these areas, somebody said I have to go from being a mother of the vanguards to being a midwife, because I have to now let go of the work is extraordinary that it's going on. The extensivist service, you will hear a bit more about it later on, really supporting individuals. I was lucky enough and privileged enough to sit through one of the consultations that one of the well-beings, they call themselves the well-beings, had with an individual. His name was John, about the support that he is having using local community assets in the way that we describe it. And you can see the impact on A&E attendances, outpatient attendances and non-elective admissions. And there are a number of other examples. We understand, because we understand the population health. Morecambe Bay, I always feel like we need a whoop when we come to talk. The Bay Way, some really impressive work going on across the whole of the community. And what's impressive about Morecambe Bay is that it is all parts of the system working together on the Bay Way. And some examples here from the health community line. I suspect we'll hear a bit more about it later on. Sunderland, the impact it's had on staff. So the bit that's given me the most joy is seeing and talking and listening to the vanguards when they talk about the impact this has had on people who are working day in and day out. Some of the pressures that Chris talked about at the beginning, and the joy that it has given them to make the differences that they're making. A GP in the south said to me, this has reinvigorated why I came into medicine, because I can do the things that I set out to do. So we are seeing the impact, and we're measuring the impact from a staff perspective. You will hear a bit more about primary care home later on. The New Care Models programme has also been supporting primary care home, which has been delivered through the National Association of Primary Care, around 30 to 50,000 population size. It really is delivering population health with professionals, community services, pharmacists working together, putting their professional rivalries aside and actually focusing on what's best for the population. And you will hear a bit more about that from Nav a bit later on. But we currently have 92 sites working on this across the country, and again led by the people who are actually delivering the services, which is an absolute pleasure to see. So the golden thread is around sustainable population health. Did I mention it's around population health and making sure that it's around the registered list of the population budget, and eventually may take on the contractual responsibility and accountability for population health. So we are also working through what this means from a contractual perspective. And if you're interested in hearing more, and there's quite a significant amount of work going on around what does the contract mean in practice, and what does this mean from a payment, how do you measure risk, how do you share risk, what's the impact, etc. Very happy to talk about that a bit later. So we set out at the beginning of the programme to identify the building blocks that need to be in place if anybody is thinking about delivering the population health or the care models. Now, we could have taken this from the myriad of examples from both internationally and also more locally in Europe, but what we wanted to do was make sure that it's context specific and that it's relevant to our health and care system for our population. So we have published these at the end of December last year. So basically these are the building blocks that need to be in place. You need to understand your population need. You need to be able to understand what is really going on in that population and then target the resources appropriately. We're not just talking about the top 1% or 2% of people on the frailty register. This is about really understanding the population and the care that is required. And without that, without a combined understanding, not perhaps in the most traditional way of what we all understand because we've all got the same data, but actually secretly we've all got our own list. This is around having one combined set of data supported by a technological platform and then targeting the resources around it. And you can see the gradients of care that is then provided. So for those of you that are more observant, you will see that the PACS model looks very similar to the multi-specialty community provider model because they are both population health models. Similar, building business intelligence systems, shared care records, and then tailoring the services based on the population need, both now and also in the future. So truly getting ahead from a prevention perspective. So it isn't just about those individuals that are using our services now, but it's also about preventing and supporting individuals in the future. And then you can see the multi-agency, multidisciplinary teams working together, whether they're locality hubs, whether they're integrated teams, whether they're PRISM teams. Fundamentally, across the majority of the vanguards, we have multi-agency, multidisciplinary teams working together in the same place, building those relationships, because without the relationships it doesn't work, building those relationships and then targeting the resources appropriately and coordinating care for the most complex and also the wider population. This is the Enhanced Health in Care Homes care model. Again, we published this at the end of last year. So this pulls out all the commonalities between all of the different types of vanguards. So it's not just about what's going on in Morecambe Bay or in Yeovil or in Northumbria. These are the common elements. If you're interested in designing and want to know how to support the implementation of the care models, these are the things. Now, the care homes are very interesting because what this is actually a bringing together. None of this is new. None of this is new in terms of what it is that should be happening around care homes. But what the care home vanguards have seen in practice is that when you do these interventions together, they have the impact that they were designed. So you do need enhanced primary care support. You absolutely do need that multidisciplinary team support working together. And it's these things working together at the same time. It's not just taking one of them and picking them off, it's all of them. And the Care Home 6 vanguards have done a superb job of sharing what's happening within the care home, within their individual care homes and also across the other 6. So as Chris said, cementing the improvements, holding our nerve, supporting the vanguards, supporting the new care models, and then spreading the success of the new care models moving forward. So over the course of this year, we don't want people to be talking about vanguards for vanguard's sake. So vanguards are there to prototype and design and test the new care models to support and underpin the sustainability and transformation plans moving forward. So we know now more than we've probably seen before, because we can see the early impact the vanguards have had, that you have to have that collaborative system leadership vision in the way that we've talked about before. That's what you see through the emerging SDPs. The relationships and the shared vision, I cannot overplay how important these are, and you'll hear more from the vanguards later on. That the vanguards have said the things that have made the difference are the relationships and building those relationships to be able to do this. Absolutely then supported by system-wide governance. It isn't just about relationships, it's not just about having those conversations, it is also about changing and working through the governance associated with it. Good old-fashioned programme governance structure. You do need a PMO, you do need to know where you are against the plans that you set out to achieve. You'll hear more about the logic models and the counterfactuals from an evaluation perspective and measuring against those. You can have a care model, but a care model in isolation that isn't supported by a detailed financial model and business model isn't going to go anywhere. But it starts from the care model and then works back. And then, of course, the team design and job roles. We have scenario plans for what type of roles are needed in the future based on the work that the vanguards themselves have been leading locally. And then making sure that we adapt as fast as we can and scale as much as we can the learning and the impact from the new care models and the vanguards, and then of course the appropriate commissioning and contracting changes that are needed. So the vanguards, we asked the vanguards what they said they needed at the beginning. We asked them at the back end of last year what were the things that they found most useful. Charles would be glad to know evaluation of metrics was there. Leadership and system delivery. Actually, what does this mean in practice? it's all very well these lovely fluffy words, but what does this mean? And actually having some time spent working that through the communities of practice, workforce, and then support around communications and engagement. They've said they need moving forward are similar, and then the commissioning, payments and provision work and the contract development work, which is the right order. Because if you don't start with the care model, the commissioning, the contracting, the governance model doesn't work behind it. So starting there, and that's the ongoing support that the vanguards will be receiving. So most of the STPs talk about a version of the care model, whether it's a population health model, whether it's a care home, or it's a locality hub, or it's primary care home, or MCPs or PACs. And our job is to support the care models and the vanguards themselves to spread and share the learning. And there's some superb events happening up and down the country. In the North East, they had a dedicated event on how do we take what's happened in the vanguards in the North East and share that across the STP and make sure we don't reinvent the wheel. Nottingham, they have 4 or 5 vanguards working together that crossed all of the STP. So basically metamorphosising from being vanguards to support the new care models, and that's the right thing to do. And making sure that we have learned and we've implemented the stuff from the vanguards and wider, because it's not just the vanguards delivering the new care models, so that we support the STPs. And if you want to know more, we do have obviously our website, and if you want to join the online collaboration tool, please do let us know. The platform, you can find everything to do with anything to do with the care models. We have a lot of conversation on social media. The Academy of Fab NHS stuff hosts stuff around the vanguards. The more we share, the more we spread. And that actually has been one of the hardest things over the last year, is enticing the vanguards to share as much as possible, because we do have quite a British approach of not wanting to say what we've done because somebody's going to have a go about it, and also really can't be that good because other people must be doing it. But the more that we share through webinars, vlogs, blogs, online collaboration tools, that's our approach to make sure that we are sharing the learning from the care models, and you can also join the conversation. So thank you very much for your time.